اللي هي أيضا محاضرة. بالمحاضرات السابقة أخذنا محاضرات 2 على البنكرياتيك سيرجري، محاضرتين على الانال كانال، واليوم والخميس إن شاء الله محاضرتين على الريكتوم. بالسيرجري اوف ذا ريكتوم يهمنا الاناتومي blood supply, venous drainage and lymphatic drainage, and to know signs and symptoms of rectal disease and how to examine the rectum, type of investigation, rectal injuries, diagnosis and management, and type of rectal polyps يعني benign and pre-malignant disease, benign condition of the rectum, and diagnosis or differential diagnosis of carcinoma of the rectum, classification of CA rectum, and headlines of management of CA rectum. Regarding the surgical anatomy, it starts from rectosigmoid junction, rectum, start from rectosigmoid junction, which lie opposite to the sacral promontory, to the anorectal junction. Here anorectal angle اللي هي 120 degree created by puborectalis muscle. The rectum has 3 lateral curvature, upper, middle, and lower. Upper and lower curves convex to the right, and the middle convex to the left. Wider part of the rectum called ampulla of the rectum, which lie below. Adult rectum is about 18 to 20 centimeter in length, divided to 3 equal parts. The upper third, which is mobile and has peritoneal coat, except near to the middle third, where the peritoneal cover only anterior and part of the lateral surface, and middle third, which is widest part, widest part of the rectum, and lower third, which lie within muscular floor of the pelvis. Then 3 parts of the rectum. Upper part enclosed with peritoneal covering. The second part just anterior, and part of the lateral posterior devoid without peritoneal covering, and lower part اللي هو extra peritoneal part of the rectum. The lower part of the rectum is separated by facial condensation, non-Villiers fascia, from the prostate and behind طبعا بالميال prostate, and behind by wall layer fascia from the coccyx and last to sacral vertebrae. These 2 fascia has surgical importance, barrier to malignant penetration. Blood supply. Superior rectal artery, it is continuation of inferior mesenteric artery and divided into right and left branches. Middle rectal artery branch from internal iliac artery, and inferior rectal artery is branch from the internal pudendal artery. مهم blood supply of the rectum. And venous drainage, superior hemorrhoidal vein drain to the upper half of anal canal above the dentate line. It become superior rectal vein, inferior mesenteric vein, which drain to the splenic vein. يعني احنا نعرف السبلينيك فين والانفيريور mesenteric vein راح يكونون portal vein. Middle rectal vein, small and of no importance channel, unless normal pathway is blocked. Lymphatic drainage usually upward, but limited extent downward. The lower part below dentate line may go to the below, but if this way blocked by malignant tumor, the way change to the side wall of the pelvis and even to inguinal lymph nodes. Superior rectal lymph node, important group of lymph node located on the back of ampulla above the levator ani muscle, lymph node of Girotta. Middle rectal lymph node. Middle rectal lymph node lie close to middle rectal artery. And the clinical features of rectal disease: bleeding per rectum must see color and amount, dripping or sealing, pre or after defecation, is associated with pain or not. Yani, bleeding is cardinal symptom of rectal disease, sometimes painless and sometimes with pain. Also, other symptoms like altered bowel habits, constipation, sometimes diarrhea, discharge, mucus discharge, tenesmus, feeling of defecation, but nothing happened. Prolapse, rectal prolapse, pruritus, and loss of weight, especially in malignant disease. Examination of the rectum includes visual inspection of the peritoneum, digital examination, octoscopy, sigmoidoscopy, which is rigid or flexible, position of digital rectal examination, either left lateral SIMS position or knee elbow position. وطبعا ما ننسى انه الباريوم enema is also of diagnostic value of rectal disease. Rectal injury. Rectum and anal canal may be injured by many ways, all uncommon, either by falling in a sitting position on a sharp object or by fetal head during delivery, ممكن يصير rectal injury, or by serious sexual assault. And regarding the diagnosis of rectal injury from history, most important question is the patient pass urine after accident to exclude urethral or bladder injury or not. يعني أول سؤال بالrectal injuries is the patient pass urine or not. Then examine anus by inspection, PR to see if blood in the finger or palpate any defect in continuity of the wall of the rectum. Proctoscopy and or sigmoidoscopy. If there is no rigidity of abdomen, but if there is rigid abdomen, usually patient need early explorative laboratory. And regarding treatment of the rectal injury after patient has been anesthetized, طبعا نبدي من الاي بي سي. اهم شيء اذا عندنا massive bleeding, 2 lines, one for fluid and another for blood. يعني blood should be prepared after massive rectal injuries and after anesthesia of the patient. The rectum is examined with the finger and with the speculum, depending on the site of rectal injury, whether above or below pelvic floor. Is it the injury intraperitoneal or the injury extraperitoneal? In both conditions, lower laparotomy was done. Cases above pelvic floor, proximal colostomy, suturing of injured site. And the cause to do proximal colostomy in order to let the injured part to heal. يعني راح نسوي diversion of the fecal material proximal to the suturing. If injury below pelvic floor, also proximal colostomy with wide drainage from below is indicated. If injured large resection of part of the, if the injured large resection of the part of the rectum in such circumstances, Hartmann procedure is indicated with the preservation of anal sphincters, with covering of antibiotic for both aerobic and anaerobic bacteria. Okay, after rectal injury, rectal prolapse. This may be partial rectal prolapse or complete rectal prolapse. And partial prolapse confined to the mucosa, which prolapses an inch or 2 from the anal verge, يعني from the anus. Palpation of the prolapse between the finger and the thumb reveals that there is no muscular wall with it only double layer of a mucosal membrane. It may occur in extreme of life. Children 1 to 3 years and elderly patient. يعني prolapse if devoid of mucosa, if devoid of muscular layer, just 2 layers of mucosa, هذا ممكن يصير بالchildren and in elderly patient. Causes in infant and develop sacral curve and direct downward course of the rectum. Diminished in amount of fat in ischiorectal fossa and fibroid cystic disease and male development of the pelvis. In adult, 3rd-degree hemorrhoid is a cause of prolapse, straining from urethral structure, and in female, term peritoneum predisposes, in female, a torn perineum predisposes to this condition. May follow an operation for fistula in ano, where as large portion of muscles are removed. Treatment of these babies requires nothing more than reassurance of parents that condition is self-curing, digital reposition with tissue paper by index finger, يعني clinics نخلي عليها وندفع. Submucous injection is digital if digital reposition failed. Submucous injections or if digital reposition is failed. يعني injection of sclerosant like 5% phenol almond oil. An adult submucous injection or excision of prolapsed mucosa. Complete prolapse is less common than partial prolapse, involve all layers of the rectal wall. It is more than 4 centimeters and commonly as much as 10 to 15 centimeters in length. It usually occurs in elderly women 6 times more common than male. It is more common in women, in elderly, 6 times more than in male. In women, usually associated with the prolapse uterus. It is uncommon in children. Apart from discomfort of the prolapse, there is associated incontinence due to the stretching of the sphincter and the mucus discharge from the prolapse mucosal surface. And differential diagnosis, ileocecal intussusception in children, rectosigmoid intussusception in adult, and the treatment of rectal prolapse. Treatment of partial prolapse in adults comprises excision of the redundant mucosa or a submucosal phenol almond oil injection in order to produce sclerosis. Many months have been described for dealing with complete prolapse. Perineal approach include tertiary wire operation, where a wire or nylon suture is passed around the anal orifice to narrow it and keep the prolapse reduced. Today, 2 procedures are commonly performed. The first is fixation of the rectum in the pelvis by an abdominal operations such as rubbing the mobilized rectum and polyvinyl sponge, which produces a brisk fibrous reaction, wetting the rectum to the pelvic tissue. B. Delorme procedure involves less traumatic peritoneal approach with excision of the mucosa and punching of the bowel muscle to form a donut-like ring, which holds the rectum in the pelvis rather as a ring. Pessary may control vaginal prolapse. And abdominal approach in management of rectal prolapse, Wells operation. This operation, the rectum is fixed firmly to the sacrum by polypropylene mesh inserted between them, between the rectum and the sacrum. Ribstein procedure. In this operation, the rectosigmoid junction is hitched up by Teflon. Then صار عندنا rectal prolapse, اكو treatment of partial واكو treatment of complete prolapse. treatment of prolapse in children and treatment in adult. عندنا perennial approach وعندنا عمليات للabdominal approach. Solitary rectal ulcer. It is ulcer in the interior wall of the rectum. It must be differentiated from rectal carcinoma and inflammatory bowel disease. Patient complain from pain and discharge. And rectal polyps. Rectal polyps, important subject because some polyps are pre-malignant condition. The rectum and sigmoid colon are the most frequent site for polyps in the gastrointestinal tract. Rectum and sigmoid colon are the most frequent site for polyps in gastrointestinal tract. Or adenomatous polyps have tendency for malignancy or malignant change, especially if polyps more than 1 centimeter in diameter. يعني هسه pre-malignant condition بالpolyps أولاً polyp more than 1 centimeter in diameter or show obvious signs of increasing size, or it is sessile rather than pedunculated. These carry pre-malignant change. Type of polyps, juvenile polyp, it's bright red, clustering, pedunculated, وmetablastic polyps, small pinkish sessile polyps, frequently multiple, they are harmless polyps. Inflammatory polyps or pseudo polyps due to edema of the mucous membrane, usually associated with inflammatory bowel disease. Adenomatous polyp, they are frond-like appearance, very large size. They have tendency to become malignant, rarely profuse mucus discharge from this tumor, rich with potassium, and may cause electrolyte disturbance. All neoplastic polyps can be solitary or multiple. All neoplastic polyps are solitary or multiple. يعني لو single لو multiple. Familial adenomatous polyposis, FAP, autosomal dominant inherited disease characterized by multiple rectal and colonic polyps around puberty, average age 25 years, and onset of colon cancer is 40 to 45 years. Type of treatment after diagnosis in FAP, total colectomy with a mucus or proctectomy, ilioanal pull-through anastomosis with the creation of reserval pouch. Other option of treatment in FAP, subtotal colectomy with iliorectal anastomosis for patient with very few rectal polyps, and ileostomy with total abdominal colectomy. Tumors of the rectum. There is benign tumors, pathologically either benign or malignant tumor. And benign tumors of the rectum, either adenoma, and good example for this is villus adenoma of the rectum, papilloma, also can occur in the rectum, lipoma of the rectum, also lipoma can occur in a lot of parts of the body, one of the sides of the rectum. Endometrioma also can occur in the rectum. Then هي benign rectal tumors. Malignant tumor of the rectum or CA rectum. This is important disease. This is important subject. Primary tumors of the rectum, malignant tumor, عندنا benign وعندنا malignant, and the malignant either primary or secondary. Primary tumors, either the commonest adenocarcinoma of the rectum or squamous cell carcinoma of the lower anal canal. طبعا هنا بالانال canal مو بالركتم، الركتم هو اعلى من 4 سنتيمتر مع الانال canal. Melanoma, rectal melanoma and lymphoma. While secondary tumors in the rectum, invasion from prostatic tumors, uterine tumor, or pelvic peritoneal deposits. إذن وصلنا للtumors of the rectum، وبالذات إنه primary tumor عندنا الادينوكارسينوما of the rectum إن شاء الله last lecture راح تكون يوم الخميس اللي هي CA rectum، وراح نتطرق بيها لل causes and predisposing factor to CA rectum. Important thing is pathology of the CA rectum and tumors of the upper third, middle third, and lower third of the rectum. And also we discuss classification of rectal tumors, adenocarcinoma of the rectum, important, اللي هو Duke's classification and TNM classification. In the rectum, investigation of the rectal disease and lines of management of CA rectum. And in line of management, there is also surgical treatment, there is conservative procedure, and there is radical procedures, and also we consider preparations of the patient for rectal disease, preparation of patient with rectal cancer for operation, and there is different option for procedures in dealing with carcinoma of the rectum. شكرا جزيلا، إن شاء الله نلتقي يوم الخميس with the last lecture CA rectum.